Can you hear me now? Can you hear me? Okay, sorry, some technical issues. Good that you can hear me now. So welcome everyone to this webinar co-hosted by the International Center for Antimicrobial Resistance Solutions, ICARS, and the Global Antibiotic Research and Development Partnership, GARDP, on strengthening antimicrobial stewardship for equitable access to new antibiotics. My name is Fabian Maza. I am MD, specialist in global health, and I work as a science officer at ICARS. And I will be the moderator for today. The aims of today's webinar is to gather insight on establishing a sustainable linkage between access and stewardship for the introduction of last resort new antibiotics. To this end, we have gathered a group of experts to share their insight, which you can see on the screen. We have then an exciting agenda lined up for you. So then we are going to start with an overview of the Tandem ABX project by ICARS, followed by updates on the GARDP work in Africa. Then we will go for an interesting presentation on the healthcare facility assessment conducted in Kenya and India. And then we will go to hear the perspective of some of the stakeholders that we invited for this webinar. And finally, we will go to a Q&A session that we expect to last around 30 minutes. And then where you, the audience, will have the opportunity to send questions to our speakers or our panelists. So now let's move on our first presentation. And I'm pleased to introduce Jyoti Joshi, which is the Senior Advisor at ICARS. Jyoti will provide an overview of the Tandem ABX project, which focuses on sustainable antimicrobial stewardship. Jyoti, the floor is yours.
Thank you so much, Fabian. And I will just share my screen. Can you hear me?
Yes, we can hear you.
And give me a minute. Can you see my screen now?
No, not yet.
Not yet. So maybe I will request you to share the screen from your side to avoid loss of time.
Sure, we can do that.
Thank you. And I will just say next so that you can carry on sharing.
That's perfect. Okay.
So is the screen visible?
Yes, we can see the screen share. So you
Great.
can start, Jyoti.
Thank you. So I'm Jyoti Joshi, and I'm happy to share this project, which it's a planning grant that ICARS is implementing with Novo Nordisk Foundation support towards developing an antibiotic roadmap for the sustainable entry and management of antibiotic X, which could be any reserve last resort antibiotic in low and middle income countries. So before I start, I would like to just explain why ICARS and why especially we are working on this. So if I can have the next slide. ICARS is basically an independent self-governing institution established only 4 to 5 years back, which provides both technical expertise as well as financial funding to agencies working in low and middle income countries to develop solutions that they can pilot, test, and scale up. We are a Danish initiated organization started with only government of Denmark funding, but today we have funding from other sources and employees starting from 2 to 35 plus today. Can I have the next slide? And why we work on AMR is the idea is to develop evidence-based, but very context-specific solutions that work for settings where so far the implementation of national action plans hasn't taken place. And we believe that if we work with the local stakeholders, such as the ministry and the researchers there, we can develop cost-effective, sustainable solutions that can cover the gap between policy and practice and are evidence-based over One Health. So the reason, and we use the intervention implementation research framework to understand what is the current context and then proceed forward. So if you go to my next slide, When we were looking at partnering with partners like GARDP and React Africa, what we see and the solutions we are actually currently funding are a lot to do with how antibiotics are used in the field. Now, when we look at new antibiotics, a lot of the new antibiotics are being developed from the bench side, and they, with the effort of many other partners such as CARBEX and GARDP, will reach low and middle income country settings. But once they reach these settings, whether they get registered and with their efforts supported to reach up to the national and state level, even if they reach the facility level, unless there is prudent use of these antibiotics only when needed, that means a very strong integration of the access efforts with the stewardship effort for these last resort antibiotics, it will be a challenge to sustain their efficacy. So can I go to the next slide? When we look at the stewardship spectrum in low and middle income countries, we see that stewardship as an intervention has been proven to be effective, but it has not been scaled up or taken up to the level that we would think would be very useful to considering the burden of AMR. And there are many factors. I will not elaborate on each because the point to take here is that there are variations in stewardship practices, the infection prevention control capabilities and capacities in different healthcare facilities. There is a lack of standardized clinical protocols, and if they exist, they are fragmented over one particular area, maybe pediatrics, but not in others, maybe in large hospitals, but not smaller ones. There is a lack of insurance coverage. The behavior of the healthcare providers is inclined to prescribe more because of this demand. And it's a vicious cycle. Unless there is reward and recognition of the AMS practices and a regular monitoring of the current practices in either public, private, or faith-based, or even NGO hospitals, there is not a larger take-up of stewardship. We see that this is due to a lack of fragmented policy drivers for stewardship and the healthcare system's capability and capacity differing across whether they are national, state, or even district level. There is variation in standards of quality of care and even the availability or even the use of diagnostics. So the challenge we see in this whole area was how to integrate stewardship into country priorities of the developing or low middle income country settings. There are many competing priorities, but this is the key challenge we thought for AMS. Can I have the next slide? So when we looked at this different, instruments, or let's say the tools available for strengthening stewardship, we found that there is a lot of guidance from WHO, from CDC, and from many other partners like BSAC. But this guidance is very high level. It is not granular for, it's about what should be done rather than what can be done or how to start. And there is a lack of a clear pathway for institutions in this type of setting for where to start. And then what are the models to follow? Because there is a huge variation even in the type of healthcare networks available in settings like, for example, India or in Africa. Plus, with the multitude of players in this area, everybody is keen to participate, but there's a lack of clarity on who should do what and what should be the sequence. So we felt it was a very important need to develop first a roadmap of how access and stewardship should work together so that antibiotics, such as especially the new antibiotics, can be safeguarded as global goods. Can I have the next slide? And creating such pathways is the aim of this project. No problem. Next slide. So what is this pathway going to look like? This pathway, coming from my last 20 years of experience, has been in implementation of healthcare programs in the vaccine world, in the disease surveillance area. So what we see is any new molecule or any new technology needs a phase of preparedness where you test the ground, prepare it, have some SOPs, implement it, and then have this introduction phase where these SOPs get tested. And then finally, they get fine-tuned based on the learnings, which can vary from desktop-based SOPs to implementation. And then finally, these are evaluated at the post-introduction phase. Now, this three-step process for this antibiotic X, which we are calling is a new antibiotic, is important. And for this, in the first phase, to develop this stepwise process, we need to have a very good understanding of what you see on the left is the downstream policy levers for stewardship, and what is the last mile journey of the antibiotic and its use being pulled in these healthcare facilities. All of this needs to get translated into the stepwise process, which then can be implemented in a pilot basis and then taken to scale. Now here we are being true to the intervention implementation research framework that we at ICARS are very passionate about. So we would like in this planning grant phase to develop a proof of concept of what is appropriate and how can stewardship be integrated in this initial phase if new molecules, which we know there are many, who will be coming into the low middle income country setting soon. So if I have the next slide. So the aim of this planning grant that we are looking at is threefold. First, to get a very granular understanding of what are the policy and systems context for new molecules that are coming into the low middle income country setting. And because we can't do it everywhere, we partnered with our colleagues in GARDP who are looking at cefiderocol, with React Africa, who is supporting AMR efforts in Africa, and GARDP partners like Find and Chai to look at two settings, one in Asia and one in Africa. So we have selected Kenya in Africa, and Asia, we have taken India to understand and do this process of what this roadmap should look like. We would like to undertake preparatory activities that are essential to collaborate with a range of stakeholders, because stewardship is not a one agency or a two agency business. There are many stakeholders that will be needed. And last but not the least, through discussion, scope and develop this theoretical framework for tandem, and then have roles and responsibilities for different stakeholders. So can I have the next slide?
Sorry, Jyoti, you have 30 seconds to close.
Sure. So this, what we are, I'll just try to wrap up soon, is we are trying to do a theoretical evidence base based on the past molecules like bedaquiline, and then also scoping activities by looking at the macro and the micro health ecosystem. If I have the next slide, we will be taking all the evidence we gather from this process to stakeholder consultations, which are going to be in Kenya and India, and develop a roadmap that is, peculiar to these settings. And last but not the least, take it to the global level, where we would hope to get greater partners to implement this and take it to scale. If I have the next slide, I think that's it. So thank you. And I hope I am able to explain this in detail, and I will be there for question answers. Thank you, Fabian. Handing back to you.
Thank you, Jyoti, for that insightful presentation. Now, let's move on to our next speaker, Lauren Jankelowitz, Access Lead for Sub-Saharan Africa at GARDP, who will update us on the work that GARDP is doing in Africa. Lauren, over to you.
Thank you very much. Just confirming you can see my screen and can see and hear me.
Yes, perfect.
Great.
We can see the screen.
Thank you. Thank you. So I'm Lauren, and I work for DNDI GARDP Southern Africa, or DGSA, which is essentially the African member of the GARDP network. And I'm here to talk about GARDP's work in Sub-Saharan Africa to date. We're also a young organization who hasn't been around for very long. Our vision is that all infections are treatable for everyone, everywhere. And our mission is to accelerate the development and access of treatments for drug-resistant bacterial infections. So how do we do this? We do this through a three-pronged R&D and access model. We firstly integrate R&D and access, research and development and access, where we engage in carefully selected antibiotic drug development and access projects to address urgent public health needs. We then collaborate and enter into novel licensing agreements. We de-risk antibiotic drug development projects by negotiating collaboration and licensing agreements with pharmaceutical companies. And finally, we bring a range of skills, knowledge, and resources to each partnership. Partnership is in our name, the Global Antibiotic Research and Development Partnership. And we in turn benefit from partners' wealth of knowledge, expertise, and experience. So this is an overview of our programs that are run globally: drug development and access in 3 different areas. The first, serious bacterial infections and sepsis. Secondly, neonatal sepsis. And thirdly, sexually transmitted infections. We run an early access program that fits into this drug development and access program called PREACT, which I'll talk a little bit more about in a minute. And it is essentially an implementers network. We then do preclinical research, access to essential antibiotics like access and watch antibiotics that we do through a WHO and GARDP DGSA joint project called Secure. And then we connect the R&D community by running scientific affairs webinars through Revive. So to talk a little bit about PREACT, what we do is we work with key partners, including national ministries of health, academic centers, and major private providers, to facilitate the development of in-country access and implementation networks for the rapid introduction and appropriate use of antibiotics in hospitals. So really the last resort antibiotic or reserve antibiotic that Jyoti was speaking about earlier. The objectives of the implementer networks are to determine priorities for the introduction of new antibiotic products, to develop costed antibiotic access strategies for both advocacy and for implementation, and to determine opportunities to accelerate, identify, and remove potential barriers to access and leverage best practice. So really this involves introducing antibiotics responsibly in countries by partnering with implementers, back to partnership again, and developing partner networks. What we try to do is to develop communities of practice and implementation partner networks of key opinion leaders for hospital-based reserve antibiotics in sub-Saharan African countries, at the moment 2 countries, Kenya and South Africa. We support countries in antibiotic prioritization or optimization exercises and define introduction pathways for reserve antibiotics, and then support any additional activities defined by PREACT members. With regards to GARDP's work, we are looking at 5 treatments by 2025, and our progress to date you can see as follows. Cefiderocol is the one reserve antibiotic that we are working on. The license agreement has been signed. We are working with a generic manufacturer, and this is enabling us to bring down the cost of goods, and we're going through a process that will enable us to approve within various countries this licensed product. But before doing that, we're doing some introduction studies, some phase 3B trials in order to see how cefiderocol can be used in the real world. Then we have cefepime taniborbactam, a new treatment which is still in development, doesn't have a name yet, still in number form, and are exploring empiric treatment regimens for neonatal sepsis. So these are existing drugs, fosfomycin and flumoxef, together with amikacin in different formulations to explore what will work for neonatal sepsis. And then finally, just recently completed the trial and the data released on zoliflodacin for drug-resistant gonorrhea infection. So the work to date in South Africa and Kenya, and then a couple of other sub-Saharan African countries, really only since last year have we been doing this work. What we've done is we've established PREACT committees, these key opinion leader implementer networks, one in South Africa and one in Kenya, and there's been a meeting of each. In South Africa, we've also facilitated the development of a position paper regarding reserve antibiotic access and usage in South Africa. And this is something that Heather Finlayson has been involved in and can talk a little bit about as one of our panelists. And then we've supported the South African Department of Health's analysis on reserve antibiotic data. What we're planning to do is to analyze colistin usage in the country, because there isn't an understanding currently of how much colistin is used and in what ways, and this is important knowledge before rolling out a new reserve antibiotic. We'd like to have another PREACT meeting to bring the team together to look at what we've achieved and what we still need to achieve. And we are planning an early introduction study more for 2025, 2026, that will look at the rollouts in a handful of sites of cefiderocol. In Kenya, we've had a pre-act meeting, and we've also had a stakeholder engagement meeting that we supported the Ministry of Health to run together with MTAPS. It was a One Health meeting and CHAI, our partners in Kenya. We are looking at a second stakeholder engagement meeting where we're looking at developing a partnership framework. We're also looking at whether a similar position paper to the one developed in South Africa could be developed as a precursor to the introduction of a new reserve antibiotic. And we have joined this partnership with ICARS and others that includes early introduction of potentially cephalosporin in Kenya. We'd also like to run another pre-act meeting. With regards to other sub-Saharan African countries, we've been looking at pre-act, but focusing more on neonatal sepsis. We've built relationships in Rwanda and in Zambia, but haven't yet started any projects. And we're planning to build relationships in Ethiopia for pre-act and to establish a pre-act meeting in Ethiopia next year, and to explore STI networks across South Africa, Kenya, Ethiopia, and potentially some other sub-Saharan African countries. Thank you very much for your time. I will stop sharing.
Thank you, Lauren, for those updates. Next on the agenda, we have Veronica Chushu, infectious disease specialist, currently working at the Foundation for Innovative New Diagnostics, FINE, as an AMR scientist, who will share insight from healthcare facility assessment conducted in Kenya and India. Veronica, please go ahead.
Thank you, Fabian. Allow me to share my screen. Let me know when you can see my screen. Okay.
Yes, we can see your screen. It's still not in presentation mode, though. Now, in presentation mode. Yes.
Okay. A bit off camera just to save on my bandwidth. Seems to be unstable. I hope that's okay.
Yes, no problem.
All right. Okay. So thank you, Fabian. I'll be presenting on an assessment that we did together with GARDP in Kenya and in India, trying to check on the diagnostic capacity and antibiotic use in select health facilities. I will start with, oops, my slide seems not to be moving.
Now it moves.
Please, Fabian, confirm that my slide can, okay.
Yes, it
all right. All right, thank you, Fabian. So I wanted to start with this slide, just to show how important diagnostics play in antimicrobial stewardship when you try to optimize the use of antibiotics to improve patient management and also to reduce antimicrobial resistance. For example, we know there are so many challenges that primary healthcare we get, and especially when we do not have diagnostics tools and when we do not have consumables and reagents. For example, when a patient presents to a healthcare facility with signs of fever and cough, there are possible outcomes that the patient could either be having a common cold, which is viral and does not need antibiotic treatment. The other outcome would be there's a possibility of respiratory tract infection, which requires antibiotic treatment, or the patient also need to be referred. But when we do not have diagnostic, then that means the patient end up getting antibiotics, and there's a possibility that that they could be ailing from a common cold that do not need antibiotics, and that leads to unnecessary use of antibiotics. And again, to continue with the challenges of that we experience at hospital level, when we have, for example, a bloodstream infection, a patient presenting with bloodstream infection, we expect that samples will be taken, a culture will be done, and AST will be done, and the result will be used by clinicians to guide patient management. But when we have challenges on diagnostics, then means most of the time this will not be done, and the patient will be treated empirically. And also when we have diagnostic, but there's low demand for diagnostic tests by clinicians. They watch it empirically, and it's until when we have therapeutic failure is when we'll see clinicians then asking for a lab test. Eventually, most of the time we'll have nothing growing, and then patient management will not as prompt as and efficient as we would like it to be. Now, going back to the study that we did in Kenya and India, the aim was to assess AMR diagnostic capacity, antibiotic use, and challenges and AMS practices in select health facilities in Kenya and India. And the use for these findings for GARDP is for the preparation in the introduction of sulfiderical, and for FIND, we are working to introduce a simplified blood culture and a molecular assay for ID and AST. So when we get these results, it's for us to prepare as we prepare to introduce the new equipment and the new antibiotics. As to the objectives of the assessment for the microbiology component, there are two components in the assessment, the microbiology component and antibiotic use component. The objective was to determine the current diagnostic use for AMR, then to determine the stability of supply of equipment and testing commodities, to establish the average cost and mode of payment for AMR diagnostics, and then to document use case for AMR diagnostics and the current practices. For the antibiotic use component, we wanted to understand the current reserve antibiotic supply, use cases and gaps, and also to identify access pathways for new reserve antibiotics, and then to map potential early adoption sites and capacities and barriers that do exist. So as I mentioned, this work was conducted in Kenya and India. So the map on the left is Kenya. We did this in 10 counties and in 28 health facilities. How we selected the 28 health facilities, we worked together with the AMRCC, that is Antimicrobial Resistant Coordinating Committee, which we call NASIC in Kenya, to select the health facilities. And the health facilities were sub-county health facilities, which would term them as primary health care, and then county referral hospital, which we can term them as secondary health care facilities, and national and teaching referral hospital, which could term them as tertiary health facilities. And in India, we also did the same, selected 30 health facilities, which were quaternary, secondary, and primary health facilities, and we did this in six states. And maybe just to mention here, because the results differ, in Kenya, our majority of the health facilities were primary health facilities, like 64% were primary health facilities, as compared to India, where 77% were quaternary health facilities. So the capacities are different. So that means the results would differ. And how we selected the health facilities in India is based on if they were easily accessible for us to be able to get the data that we are looking for. And now going to the results, we wanted to check what capacities in terms of training the staff conducting microbiology tests in the labs have. If you look at Kenya, majority of them had diploma in medical microbiology or medical laboratory. If you compare this with India, and again, I said the capacities were different, the level of health facility that we assessed were different. If you look at India, majority of them had master's degree. We also had some that had PhD. There were also medical doctors and some that had bachelor's degree in medical microbiology. So looking at going back to Kenya, we're looking at if there are any trainings that when we have new employees in microbiology they get. 29% they said no standardized process for training new employees, and 64% of the health facilities stated that they receive annual competency training. So going to the capacity to conduct bacterial and fungal cultures. So this is Kenya. We found that out of the 28 facilities that we assessed, 13 did not have capacity to perform cultures. So that means 15 had the capacity to perform cultures. So again, stating that most of the facility we assessed were primary healthcare. Those are the majority were level 4. If you look at the 13, so most of them were coming from the level 4. So looking also at the capacity to do blood cultures, out of the 15 that were able to do the test, then only 8 could perform blood cultures, 5 had automated BC blood cultures, and 3 were doing it manually. If we look at the type of cultures that they could be able to do, the majority of them could be able to do stool cultures, PAS, HVS, genital urine, and so forth. And then checking if out of the 15 that could be able to perform cultures, how many could proceed to doing antimicrobial susceptibility. And we saw out of the 15, 14 had the capacity to do antimicrobial susceptibility. Looking at India, so out of the 30, 26 health facilities were able to provide culture. So then the 4 that were remaining, 3 of them were the primary healthcare, and 1 of them was the secondary healthcare. So then again, the 26 could perform blood cultures, but 21 of them were using automated blood culture machine. So the BC mainly were procured through hospital budgets and the national government. Then again, checking on how many could be able to do antimicrobial susceptibility out of the 26 that could be able to do cultures, 22 of them would proceed to doing antimicrobial susceptibility. And then we wanted to check on what were the barriers or what are the challenges that health facilities are facing to be able to perform cultures and antimicrobial stewardship, antibiotic susceptibility testing. The majority of them in Kenya, they said that is lack of equipment. That is the biggest issue that we have. And then the lack of reagents and stockouts was another big issue. But they also said inadequate infrastructure, mentorship they didn't have, and personnel. But looking again at those that had automated blood cultures, they said that they did not have service contracts, they usually get regular stockouts and lack of trained staff. When looking at India, they mentioned the challenges that they have were lack of consumables, breakdown of culture machine, and lack of staffing. Then looking at the barriers that specifically for blood cultures, and this is Kenya. So majority they said lack of equipment, that they are not able to do blood cultures. But if you could see at what I have marked here, there is one that is low request by clinician. And what does that mean? If you have low request by clinicians, means that mostly they will treat empirically. So it means that they will give antibiotics, and it is only when we have done therapeutic failure is when they will tend to request for test, which means that we need to do something on antimicrobial stewardship, and so that they are able to request for cultures early enough so that they can base their treatment on lab results. So looking at the cost of culture and AST. So in Kenya, the average cost from the data, cost for culture and AST is $12, ranging from 1.5 USD to 22. So maybe I forgot to mention that the kind of health facilities that we were assessing were private health facility, government facilities, and faith-based facilities. So the cost, of course, will range depending on where the patient is treated. And specifically for blood culture, then the average cost was $15, ranging from 8 to 46 USD. Looking at India, the average cost for culture and AST is 9 USD, again ranging again from 4 to 16, because again we used the same approach, private and public. For blood cultures, average was 9 USD with a range of 1 to 22. And then specifically now looking at the antibiotic use component, and this one specifically I will speak for Kenya. So we wanted to check on availability of guidelines, antibiograms, and how is the demand for bacteriology? Do they have cumulative antibiograms? Do they have AMS committees? So out of the 28 health facilities that we assessed, only 2 at the time of assessment mentioned that they had a cumulative antibiogram. And also looking at the availability of guidelines, 39%. They get guidelines. Those could be the ones they have at the national level, using the ones at the national level, and also facility level guidelines. And looking at the demand for bacteriology, 69% of the health facilities say demand for bacteriology is driven by clinical signs. So we also wanted to check how aware are the health facility on the aware classification of antibiotics. So we saw that if you look at the level of health facility as you go up, it means they have a higher awareness of the classification. As you go low to level 4, which is primary healthcare, they have a low understanding of the aware classification. And looking at either the health facilities, faith-based, private, or public, those that are in the faith-based health facility showed that they have a lower awareness of the aware classification of antibiotic. So we also wanted to check on their training on antimicrobial stewardship. And staff from 13 health facilities out of the 28 said they had attended AMS trainings. And looking at availability of stewardship guidelines and policies, 7 health facilities out of the 28 said they had guidelines. Looking at having antimicrobial stewardship committees, because we know this is a very critical body in a health facility if we want to reduce and ensure there's a proper use of antibiotics. The AMS committee is critical. 12 health facilities said they had AMS committees. 1 was not functional at the time of the assessment, and 8 were in the primary level health facility. And most of these AMS committees were established in 2023, which is when we did the assessment. That was last year. We did the assessment for Kenya in 2023. The one that was the oldest that began in 2016, which is commendable. So we wanted to also check on how they treat various infections empirically. So just giving an example of pneumonia, community-acquired pneumonia and hospital-acquired pneumonia. So if we check at community-acquired pneumonia, majority of them said they would give amoxicillin followed by azithromycin, penicillin, gentamicin, and there was 1 health facility that said cefuroxime going down. Looking at hospital-acquired pneumonia, so majority said they would give ceftriaxone, gentamicin, going down vancomycin, going down to 1 of the health facilities said that would give tazobactam and cefazolin. Sorry. But then we wanted to check on access antibiotics. Just check the availability of the kind of antibiotics that they have in the facility. And just showing, I have a table on the right that has different colors, green, blue, and I think that is mustard. So if you see green, it means that the drugs were available in all the 3 levels of health facility. So the first level here is level 4, which you said is the primary healthcare. Level 5 is the secondary, and level 6 is the tertiary. So we can say that the primary, which is the level 4, has more of the antibiotics that the other health facility do not have. So we checked, and the chloramphenicol was available in the level 4, but was not available in the facilities, the level 5 and 6 that we. And looking also at the watch antibiotics, similarly, we could see that level 4 had more of the antibiotics as compared to the level 6. So this is during the time of assessment. And also checking again.
Sorry, Veronica, that I interrupt. You have 1 minute more to finish.
All right.
To wrap
All
up.
right.
Thank you.
All right. So looking at the reserve antibiotics, we could see that the health facilities that were having linezolid, we could see 9, colistin, fosfomycin. And again, looking per level of health facility, we could see that the level 4 has more. If you see green again, it means that in all levels, you can see level 4 here has this, which is not also in the other levels. Polymyxin B was available in level 4 and level 6. I think I will stop there. I just picked the highlights for the assessment, and I will stop there. Thank you so much. Back to you, Fabian.
Thank you very much, Veronica, for sharing those results. This is really valuable. So now we are going to pass to the next part of our webinar, which we are going to hear in the reflection from our stakeholders. So our panelists will have 5 minutes each to comment on how these efforts align with the need to strengthen stewardship for the introduction of last resort new antibiotics. So we encourage the audience to submit their questions via the Q&A function through the webinar, and we will address as many questions as possible during the Q&A session. So our first panelist today is Dr. Heather Finlayson from the Federation of Infectious Disease Society of Southern Africa. Dr. Finlayson is an experienced infectious disease pediatrician with over 15 years of experience in the South Africa public sector, and she also has served on the Ministerial Advisory Committee for Antimicrobial Resistance. So I'm going to open the floor for you, Dr. Finlayson, to give us some input. Thank you.
Thank you, Fabian, for the introduction, and thank you for all the presenters. You presented on a very important topic about getting reserve or new antibiotics into low middle income countries, where we know that AMR has the greatest impact and consequences. And while access antibiotics or access to first-line antibiotics is really important, we do need to also focus on the other end of the spectrum, where antimicrobial resistance is causing a lot of morbidity and mortality. And I think they've highlighted the complexity of the problem within low middle income countries, and that it's not just really related to resistance, but the different factors that cause resistance, and how it needs really a multidisciplinary approach to combat antimicrobial resistance. I think really, when I think about new drugs and how we introduce them, it's really this conflict about trying to get drug companies to produce new antibiotics, but then at the same time, we kind of tell them that we want to steward it and use less of it. So it's really about trying to align this push and pull of getting new antibiotics into low middle income countries. And I think all the presenters have really broken down this very complex landscape into really, really biteable sizes that we can target individually. And I also think they've really highlighted that this is a multi-partner approach, where we all need to really work together to combat antimicrobial resistance. So I think just thinking about the 3 different presentations, I think Joshi in her first one highlighted that there's really this macro and micro level that we need to focus on, and that many countries really have policies looking at antimicrobial resistance and stewardship, but it's important to think about how we actually introduce these policies and implement these policies at the micro level. I think Lauren highlighted the importance about engagement with producers, and I think this is very important in getting the production companies on board, so that they, in fact, are also interested in introducing these antibiotics into low and middle countries. And then I think Veronica at the end did talk a lot about the importance of access to antibiotics, first of all, but that diagnostics, if we don't have diagnostics, it's very difficult for us to know how to use antibiotics. That standard treatment guidelines are very important, and I think she highlighted in hers how there are very few standard treatment guidelines in some areas. And then importantly, again, at the micro level, that we can have all these other things, but that we really need doctors to buy in into stewardship, and when we introduce these really precious antibiotics, because we don't want to lose it. I think that's all I've got to say. Lauren did mention that I recently wrote the position paper for GARDP in South Africa, and I think that really highlighted the complexity of the situation and trying to kind of identify which antibiotics we need and which and really how to introduce them was really difficult. In South Africa, we actually do have some data about surveillance and what antibiotics are used and what organisms we have, which I think makes it a lot easier. But I realize that in other low middle income countries, as we saw kind of the difference between India and Kenya, those problems might be difficult in different areas. So it's important to kind of have this very individualized approach in some countries, depending on what their resources are. Thank you.
Thank you very much, Dr. Finlayson, for your reflection. I'm going to share again my screen and present our next panelist, Dr. Kamini Walia. She's Senior Scientist at the Indian Council of Medical Research, ICMR, with over 20 years of experience in public health space. Dr. Walia is currently leading the antimicrobial resistant initiative of ICMR, which focusing at various aspects of AMR, including surveillance, antimicrobial stewardship, and One Health aspect. I'm going to stop sharing and invite Dr. Kamini to give her reflections.
Thank you, Fabian, and thanks for inviting me to this very interesting session. Indeed, the three presentations were, I think, eye-opening in terms of what kind of capacities exist in low middle income countries, and all the three speakers highlighted the importance of antibiotic stewardship, the importance of introducing new last resort antibiotics, and why we should be concerned about antibiotic stewardship for these antibiotics. And antibiotic stewardship actually cannot be done without having good diagnostic support, and also good infection control practices in a hospital or in any health or community setting. For purpose of today's session, we will focus only on the diagnostic stewardship. And this was highlighted by almost all the speakers, the importance of diagnostic stewardship, especially the last presentation, which actually talked about the available healthcare diagnostic facilities and healthcare facilities in India and Kenya. Now there is, in last few years, there is now increasing momentum around supporting availability of diagnostics at all levels of healthcare. And I think one of the key instruments for that is a National Essential Diagnostic List. In India, we have a National Essential Diagnostic List, and which mandates that every district hospital should have a culture system, whether it is a manual or whether it is an automated system. And that is the reason I think in this survey, which has been completed in Indian hospitals, they also found that quite a few hospitals had procured automated systems. As you would imagine, this is relatively new for all these hospitals, so the supply chain and availability of human resources, it is taking a while to kind of come up to the speed, but there is willingness to procure all these systems, at least at the district level. So what is also important is that a lot of antibiotic prescriptions happen at the primary healthcare level. And over there, we do not have a facility for the culture. But then there are so many other options and diagnostics which are available. For example, malaria diagnostic is available at a PHC. If we are able to utilize malaria diagnostic well, the urine microscopy well, a lot of antibiotic use can be streamlined. Now, in this session, we are particularly focusing on preventing the misuse of last resort antibiotics. Now, these last resort antibiotics will have to be used by hospitals which treat very sick patients, mainly having ICUs. So every country, I think, need to put together a system where the misuse of these drugs can be avoided, and for that, we should not shy away from mandating that the hospitals which procure these drugs or which decide to use these drugs should be allowed to do so only if they qualify, having a good lab, having a full-time microbiologist, or having a system for audit and for monitoring the use of the drug. So these kind of facilities must be available in these hospitals. It is a difficult issue of access versus the stewardship, but I think the life of these drugs, the longevity of these drugs, is must to save lives in future, and that's why it is very important that before these drugs are introduced in low middle income countries, we should take steps to prevent their misuse. And all the three speakers, I think, gave an overview of what kind of capacity exists in the countries, and more importantly, what are the gaps and uh, on which we should be working on. Thank you.
Thank you very much, Dr. Kamini. Then I will pass to the next speaker to share again my screen. So then I will present Dr. Kaunda Jamba. She's a medical doctor and clinical microbiologist with over 15 years experience in managing infectious diseases in public health facilities and 10 years in antimicrobial resistance surveillance and research. She's currently working with REACT Africa Network as an AMR NAP implementation consultant and technical advisor. So then over to you, Dr. Kaunda.
Thank you very much, Fabian, for that introduction. And thank you to the speakers for highlighting the different diagnostic challenges that we have in low and middle income countries. Just to build on what the presenters have already talked on, as well as the two panelists that came before me, I think we all understand by now to say antimicrobial resistance is a big challenge, and that the current resistant trends that we have, especially in low and middle income countries, need for us to have new molecules, especially last resort treatments. However, before we think of the introduction, I like the process that has been highlighted in that there was need to understand the landscape, what is going on in each country, as the different countries would have different priorities as well as different situations that are prevailing. I think that was also highlighted in Dr. Veronica's presentation. So we need to understand that access without stewardship will be a drain on the new molecules that are being produced, and we'll find ourselves in the same position that we are at currently. However, we know that access is driven by data that is generated from the different countries. That's why it's important to have to strengthen our diagnostic capacity. I think this has been echoed by all the presenters that have come on before me. We need a strong diagnostic capacity that will help us know what type of resistant trends we are dealing with, as well as build the case for what type of new molecules we need to introduce in the different countries. We know that the first presenter showed the three different molecules that are going through the different processes. Having the data from different countries would help us prioritize which antibiotics should be introduced first in the different countries. We also need a robust surveillance system, which has capacity to do both active and passive surveillance, as this will not only help us with the existing resistant trends, but it also help us monitor the emergence of the new antibiotic resistance that are going on. I like the presentation by Dr. Veronica, which was highlighting the diagnostic capacities and how many facilities did have antibiograms and treatment guidelines that were actually generated from their locally generated data. So this is important in that it will help checking or assessing whether once we have the new molecules, the clinicians or the other healthcare workers adhering to the treatment guidelines that are there, as we know that adhering to treatment guidelines will help preserve the antibiotics and prevent further emergence of resistance. We also need to make sure that once these molecules are introduced, that there will be uninterrupted supply, that will be an interrupted supply, that to build confidence in the treating clinicians to say if they need these antibiotics, they are available in good time. So once all this is in place, we know that we need to build capacity to have fully functional multidisciplinary stewardship committees. These will not only prevent the emergence of resistance or the spread of highly resistant pathogens through WASH and IPC, but they will also make sure that the clinicians are adhering to the treatment guidelines, and they will make sure that they enforce that those that are not adhering are able to adhere. So in summary, we really need to make sure that things are in place before these molecules come in and before we end up losing them. And also just to touch on what Dr. Veronica spoke to, the law request by clinicians, I think if we have a robust or strengthened diagnostic capacity where they know that if we request for these tests, we'll get the results in good time and it will help us actually manage the patients. And also there's an interrupted supply to the different molecules that they need to use. I think this is a problem that can be sorted out with having fully functional stewardship programs. Thank you.
Thank you very much, Dr. Kaunda. I will then present our next panelist, Dr. Nusrat Shafiq. She is professor in clinical pharmacology unit at the Postgraduate Institute of Medical Education and Research in India. Her team focuses on different domains contextualized to low and middle income countries, among which it's worth highlighting the establishing models and tools for enabling AMS, implementable policies, and understanding antibiotics availability and supply chain. So then over to you, Dr. Nusrat.
Thank you, Fabian, for that kind introduction. And I would like to really thank all the speakers and panelists before me for setting the stage for the current discussion. And I would like to accept that every point that each one of the presenters made was worth concurring with. So having said that, I mean, it is needless to say that we are now living in a very paradoxical situation where the newer antimicrobials are largely required in areas where the stewardship practices, be it diagnostic stewardship or just audit and feedback practices, are rather shaky. The surveillance mechanisms are in place to some extent, but we all would need to agree that they're patchy, that things are looking up, but there are miles to go. Having said that, I would also want to emphasize that these are areas where we really need these antimicrobials. At the moment, we are just our last resort antibiotic in most of the situations are polymyxins, be it colistin or polymyxin B. And that leaves us in a situation of very little to choose from. And any new antimicrobial which is available would be welcome. We have certain models in place in past, and we can draw a lot of lessons out of those models for making the entire process of monitoring, audit being in place, and the use remaining rather restricted. More than restricted, I would say prudent. We had lessons from bedaquiline, we had oseltamivir, and more recently during pandemic, some of the institutes like ours had established systems where we could deliver the drugs at a short notice in a very supervised manner. So nobody was really deprived of the required medication, but everybody, there was a mechanism to set in place that the drugs were not used indiscriminately. That is one thing. So we have a lot of lessons within these regions which can be leveraged upon. The second thing is, and importantly, these are not, very costly or resource-intensive mechanisms. We just have to be mindful of the fact that we would need the drugs at a very short notice because it is usually sepsis and a rapidly downhill patients who go rapidly downhill. So we need it at a short notice. So all the drug supplies have to be housed locally. The mechanisms would need to be set in place locally. But once we set the mechanisms, we also have to be very cognizant of the repercussions that may occur. And in fact, preparedness in the beginning would help us in dealing with a situation like this. For example, say we start rolling out such a thing in a setup like ours, for example, there are neighboring institutes, patients there, and patient care groups, healthcare advocacy groups would start pressing for making those drugs available in their healthcare setups also. So that's something that we need to be very well prepared for. Second thing I would want to say is that we do have diagnostic capacities in some of the tertiary care institutes and many other corporate hospitals, and to a great extent in secondary care hospitals also to a great extent. But keeping in mind the kind of patients in which all these new drugs would be needed, we have to be very sure that our positivity rates turn out to be very poor, even in the best of setups. And this has to be thought through, because when we're talking about stewardship and making policies and plans, we have to keep in mind the pathway for de-escalation. How do we go about those steps when we come to it? That is another thing that I wanted to emphasize upon. Third thing would be sustainable availability. One of the speakers did mention that they are tying up with the generic companies where such a sustained availability of these drugs could be at affordable prices, could be ensured. What is more very important is to understand that subscription model has been very useful when we talk about creating a balance between pull and push, and the companies losing an interest in continuing with the production. Those kind of models could be very useful, and we can perhaps draw out a few learnings from there. The other thing that I wanted to mention, and it somehow goes away from most of our discussion, is that when we try to bring in a new drug, the bringing process starts much earlier. These countries are conspicuous by their absence for most of the late phase clinical trials for these drugs. And that's something that we should start working on too, because if we see, one of the questions that is available at hand for newer antibiotics is how does it compare with colistin? I mean, that's a question which would be very important to these settings. And we just have a retrospective data to tell us about that. So those were some of the points that I thought I would highlight. And having said this, I think we will be there for some specific questions that are directed at us. Thank you. Thank you.
Thank you very much, Dr. Nusrat, for your insights. I will then pass to our last panelist. I'm going to do a short introduction. So we have a Dr. Emmanuel Tanui. He's a specialist pharmacist working at the Ministry of Health in Kenya as the national AMR focal point, with over 10 years of experience strengthening public health systems from One Health perspective. And currently, he also serves as the chair of the National Oversight Mechanism for the Commonwealth Partnership for Antimicrobial Stewardship Program in Kenya. So over to you, Dr. Tanui.
Thank you so much, Fabian, and much appreciation to ICARS and GARDP for inviting me to share my reflections on the presentations that have been made by the speakers before me. I think those were very excellent presentation. I just want to write on the remarks that has been shared by the panelists before me, and I think the presentations have clearly highlighted what is very necessary for us to be able to ensure that we have proper systems to prolong the availability of our last resort antibiotics. We have seen the work from a tandem project, the proposed preparatory work, and the proof of concept before introducing these very critical antibiotics. We have seen the work in ensuring proper sustainability, collaboration and partnership work that is necessary so that this work can continue in the long term from the GARDP initiatives. I think what I also wanted to highlight is the importance of doing the proper assessment of capacity that exists in terms of diagnostic and even antimicrobial stewardship practices in our facilities. And you could see from the report that was shared by Dr. Chuchu about the inadequate capacity in our microbiology labs to be able to perform proper cultures, which is very necessary to guide some of treatment associated with use of reserve antibiotics. So it is very important to balance access, stewardship, as well as innovation is like a three-legged stool where if there are inadequacies in any of the pillars, you may drive either inappropriate use and finally resistance, or you may constrain availability of these very resourceful antimicrobials. First, if when you think about strengthening stewardship practices so that we can be able to have these reserve antibiotics available for long, we have seen the importance of targeting the use so that we use them only when it is absolutely necessary and when this treatment has been guided by appropriate diagnostic measures. We have seen the importance of education and training where these health professionals are guided on the proper use, including how to prevent even the spread of infections. We know that any infection that has been prevented, it means that we have conserved the use of an antibiotic unnecessary. In terms of ensuring that they are functional AMS programs, the importance of having evidence-based guidelines, ensuring that antibiotic stewardship teams are fully functional and guiding treatment in these facilities, and even the importance of surveillance teams so that we know whether our interventions are functioning. We need to balance these. However, we have seen challenges that have befallen most of the LMICs in terms of having strong linkages between access and stewardship, challenges around cost of these reserve antibiotics. And we are happy that, for example, some reserve antibiotics, there are proposals to have models that get around the challenge of costs, where we have financial incentives, regulatory arrangements that are able to provide these antibiotics without the regulatory challenges. The issue of infrastructural challenges at our health facilities. We are glad that the assessment that was done was able to point out some of the gaps that are already present so that we can be able to address them. And by the time we are providing access to these last resort antibiotics, we have addressed all these challenges in terms of diagnostic knowledge, practices, behavior, and even future sustainability of our programs. Thank you so much.
Thank you very much, Dr. Tanui. So now I want to extend my thank you to all the panelists and the speaker for their informative contributions. We will now move on to the Q&A session. So for the audience, please type your questions in the Q&A section and we will try to address them accordingly. So I think we already have some of them. Some were already answered by our speakers and panelists. Maybe if there is any important, we can come back to them so everyone can hear the answer or hear the expand version of it. But maybe we can start for this question, which was addressed to Dr. Kamini, although I think that will be as well interesting to hear the opinion from other panelists and speakers as well, if it's possible. So then, Dr. Kamini, the question said, how do you envision, will you say that the case for the need for new antibiotics like cefiderocol has been established in these low and middle income settings? And could you point to the data on this?
Yeah, thank you, Fabian. This is a very important question because we have been publishing this data annually from the ICMR-AMR surveillance network, which actually collects data from more than 25 tertiary care hospitals across the country. What we are seeing is that we have very high resistance to carbapenems. It is almost going as high as 40 to 50% in E. coli, 70% to Klebsiella pneumoniae, and almost more than 80% to Acinetobacter baumannii. So when we have such high rates of resistance to carbapenems, the only drug that we are able to offer is colistin to these patients. And many a times, because of the toxicity issues, the patients are not able to respond to colistin, and we are not able to treat them with colistin. So we definitely and desperately need more therapeutic options. The piperacillin tazobactam, the rates have also been increasing. As a result, for a very sick patient who actually comes into ICU, we need more therapeutic options, and that is why cefiderocol would be very, very important. But what is also important is that we continue to understand what mechanisms of resistance are playing out in the pathogens which we are isolating from the patients in India. And what we have seen is that a good number of E. coli cases, E. coli isolates express penicillin binding protein 3. In these isolates, actually, cefiderocol also will not be effective. So cefiderocol is definitely needed for isolates which are gram-negative pathogens, which do not have PBP3. For them, the patients will be very, very, they will immensely benefit from introduction of cefiderocol in India.
Thank you very much, Dr. Kamini, for your complete answer. I think that that was quite clear and informative. I don't know if someone else from the panelists, maybe from Kenya, want to expand a little bit, or maybe the speakers, if they have something else to add to that answer. No. So that in that case, let's move to another question. I can see that some of our participants are having issues seeing the answers that our speakers made. So I will just comment on it. So this one was addressed to Dr. Lauren. So could you please expand on the use of data on colistin prescribing? Is this some sort of surrogative marker for drug-resistant organism requiring cefiderocol? Over to you, Lauren.
Hi. Yes, it essentially it's used as a proxy, so we can understand how to plan for the introduction of a drug like cefiderocol. Obviously, it's not an identical surrogate where you can match it one for one, but we do understand, like Dr. Kamini has said, that there are some difficulties in toxicity and in using colistin. Also, that there aren't a lot of options, that there's very few options, particularly where there is resistance. And so we need to understand the data of the existing reserve antibiotics that are being used so that we can properly forecast and properly plan for the introduction of a new reserve antibiotic.
Perfect. Thank you very much, Dr. Lauren, for your answer. I think that I will then pass by to this question to our speaker, Jyoti. A moment, I opened. So one of the question is, what is the plan or the timeline after this 1 year planning grant? And then there is a follow-up question asking if there is a structure in place to tie health system funding to the implementation of antibiotic stewardship programs.
Thank you, Fabian, and that's a great question. I tried to answer some of it on the chat, but I think coming back, this is a new territory in the sense like the molecules are coming for the first time in a different manner with GARDP, and hopefully many more should come with many other supporters. The idea of taking stewardship to scale by integrating it into developing country priorities and developing a blueprint that links both access and stewardship is what we would try and do. We've been interacting with a lot of stakeholders, and it seems very ambitious, which I think it is, but it is also the need of the hour. And with strong local partners in Kenya and India, I think it's realistic. So what, like I was explaining, we are currently doing is first developing it theoretically. We are sitting at the desk, looking at the previous evidence of molecules like Dr. Nusrat has also mentioned, bedaquiline, oseltamivir, and even technologies for diagnostic, and seeing how they have been scaled up, and trying to assess those pieces that can be put in place so that we can start preparing systems now in a select model of sites, which could be a mix of both public, private. This is all the plan for the 1-year planning grant. We will take this model with the scoping activities and interactions at the country level, and hopefully eventually develop a long-term proposal, which should be 3 to 5 years at least, to develop and implement this model in the field in probably India and Kenya. So this should lead to a long-term work. And this is not going to be done only by ICARS or GARDP alone, with even the countries alone. But the idea is to do partnership and seek solutions. We may succeed in some, we may not, but during the process, we will get a lot of learning, which I hope will benefit not only the molecule or the one drug we are talking on, but all others. And the last point I must add is it's also an opportunity that new drugs are coming in for this very resistant infections. And we are focusing on this opportunity because these drugs are needed in a very controlled setting like an ICU or in a very sick patient where acute decisions need to be made. But there is also an opportunity to do better in terms of stewardship initiatives. It is high priority. Hospitals will prioritize it. Clinicians, healthcare workers, patients, and their caregivers will prioritize it. So if we can use this opportunity of a new molecule in an ICU kind of a setting and strengthen stewardship at scale, then definitely it can then pass on to other antibiotics which are in the access or the watch list. So I hope that answers the question. Over back to you.
Thank you very much, Jyoti. Yes, I think that it answered that question. Dr. Nusrat, you have some comments on it, please.
Yeah, so thank you, Jyoti, and thank you, Fabian. Yeah, I would just like to exemplify what Jyoti had said. We have the latest kid on the block amongst antibiotics was ceftazidime, avibactam, and aztreonam combination. We just did an audit of the usage of this antimicrobial in our hospital, which has an audit and feedback system in place. And we realized it was very reasonable. There was a use which was not substantial considering the number of patients where such a need would have arisen. Since there is a culture of stewardship, they would reach out to the stewardship team and ask for the option of using this agent. So that's something which is good. Over the period of time, stewardship practices have been, to varying extents, been established in certain institutes, and I think all those things can really be leveraged upon. Yeah, so that's all I wanted to add. Thank you.
Thank you very much, Dr. Nusrat, for expanding this and give us your insight. I have another question. This time it was addressed to Dr. Shushu. So they were asking, like, if for the mapping on diagnostic capability to perform AST, were you able to collect information on the methodology used by each facility? For example, automatized commercial methods like BTEC, diffusion, and this person said that she think that it will be help map which laboratory can perform susceptibility testing for some of the reserve drugs which require a MIC-based method.
Thank you, Fabian, and thank you for the great question. So yes, during the assessment, we were able to check which facilities have what capacity to do AST, and of course, very minimal. I did not put that in the slide, but I think there were very few that had BITEC for doing AST, and most of them were using disk diffusion to do the AST. But of course, we will share the report widely once we have that finalized so that people can be able to see what capacities that we had. And on checking what specific antibiotics that we were using in the labs, that we did not do. Maybe that will be our next steps after this. But yeah, we are happy to share the report when it's finalized. Thank you.
Thank you very much, Dr. Chichu. So actually this question goes for the panelist. The first is like, I think that it was a little bit clear with all your inputs that it's really important and necessary to link access and stewardship. So it's like asking if, based on your knowledge, what kind of model do you suggest? How can this be done? And maybe which kind of challenges you can envision it or like could arise in linking access with the stewardship? Open the floor to the panelists or the speakers if they want as well to add.
Can I go first?
Yes, please. Thank you.
So I think there cannot be one model. There is a overall consensus that we need to reduce the watch and the reserve group of antibiotics. In India, we use a lot of watch antibiotics, and we need a consensus. There is a consensus that we should reduce the use, and also that there should be a balance between the access and the stewardship as we include last resort antibiotics. But what is challenging is that can we have a model which works in every country? No, every country has a very different healthcare system and has its own challenges. So that's why we need more participatory kind of a model as well, because everyone, if they have to implement it in their healthcare settings, they should not feel that it is being imposed on them, and it is not something that they would not like to implement. So that's why it needs more. First is to improve education around it, even among the medical fraternity, that why we need an approach to have a more responsible use of these last resort drugs. And then second is to understand what kind of capacities exist, and then based on the capacities that exist, we create a model that will be acceptable to all, and something that achieves the aim of having more responsible and the rational use of these last resort antibiotics. Thank you.
Thank you very much. Maybe someone else, we can have someone else from the panelists to, yes, Dr. Nusrat.
Yeah, so I think it has, oh, sorry, go ahead, please.
Oh, you can go ahead. I'll go after you.
Thank you. Very true, it has to be variegated in nature. And some of the and we'll have to break down the models into several components. For example, when it comes to people who will manage it, there has to be teamwork and it has to be multidisciplinary. Second thing is, this would be at the institutional or healthcare setting level. And second thing, there has to be a mechanism for distributing the drugs, dispensing the drugs in a timely manner has to be set up after assessment of something akin to inclusion criteria, but not exactly inclusion criteria. Eligibility criteria is something which would be more. Okay, and then we build it up, we top it up with a mechanism for follow-up and which with regards to outcomes, development of resistance, de-escalation, and all these elements so that we get better informed for the next lot of patients. One of the biggest challenge, which I think I see, is advocacy groups from other healthcare settings where such a mechanism is not in place, but the need is there. So that is something that I would like to re-emphasize upon. Yeah, so those would be my little bits on the model and the challenge.
Thank you very
Thank
much,
you.
Dr. Nusrat.
I think just to add to what the two panelists have said, I think there's no, when it comes to models, it's not a one size fits all. I think Dr. Tanui and Dr. Veronica both highlighted the importance of having the assessments in the different countries. So once we have the different assessments, that helps us in guiding the different models that will fit in the different countries. You might find that what fits in South Africa might not fit in Zambia. Even if you have a general model, you do have to have a country specific, depending on what you do find, like what's the landscape that's already in existence. So I think for me, we need to have the different models that will work depending on what is on the ground and what is already established. Thank you.
Thank you very much, Dr. Kaunda. I pitifully will need to stop here and just ask for the speakers and panelists if they can do some closing remarks to, I think, Veronica, maybe you can fuse a little bit both your comments and your closing remarks on this. Thank you.
All right. Thank you, Fabian. I also wanted to chime in on the discussion on antimicrobial stewardship. It pretty seems to be a new concept to most of the health facilities, basing on the results that we had. Only two of the health, not so many health facilities had antimicrobial stewardship committee, and if they exit their functionalities is questionable. So how we make this work, we might need to support the health facility to first establish the antimicrobial stewardship committee, and then again support them to develop AMS program and support them to implement this. But how do we again make sure that even if organizations like NGOs support health facilities to develop AMS committees and support them to develop work plan and support them, because of course most of the time when NGOs support health facilities, it's not going to be for a long term. If it's 1 year, then the health facilities will be left to work on their own. But how do we build an investment case to ensure that health facilities can, on their own, implement the programs on their own? So we need to build an investment case, show that there is need for this antimicrobial stewardship program, so that health facilities can be able to take that, and eventually they will be able to see the results. Of course, at the end, we'll see this reduction on use of reserve antibiotics, and what does that mean to the health facilities in terms of cost. For example, if an antibiotic in the reserve class is expensive, and then we reduce the consumption of that antibiotic in the health facility, means that the hospital is able to save on that cost. So we build an investment for them to be able to see there's some money they are saving on implementing the antimicrobial stewardship program. Of course, we are telling them there are resources that is needed for you to implement this. Anyway, to just close, thank you so much, Fabian, and to the team, thank you for having me to present this. We are happy to be part of this discussion and also looking forward to future discussions. Thank you.
Thank you very much, Veronica, for your comments. And definitely it's needed to have like an economical case and financial case for stewardship as well. Someone else from the panelists want to do some remarks, closing remarks?
Yeah, maybe I can say something.
Sure.
Yeah, first is to appreciate the organizers for the webinar. I think it's been very resourceful, and it's been an opportunity for us to learn and share our thoughts. As the other speakers have mentioned, there is no one model that fits all scenarios. Our health systems have different capacities and at their different levels of development. And I think the approach that has been selected, for example, in Kenya, I think really was in recognition of the need for us to be able to establish at what capacity we are, so that we can be able to address those gaps to reduce inappropriate use. We are different regulatory, we have different regulations, and we know regulations can either be a challenge or it can be a facilitator. So it's good to sort those regulatory hurdles. Otherwise, thank you so much. I believe that we have been able to gain some knowledge and even share our experiences in the different setups. Thank you.
Thank you very much, Dr. Tanui. So then I will want to give again, thank you for all of you panelists and the speakers for your participation and for sharing your valuable insights. So then this concludes our webinar of strengthening antimicrobial stewardship for equitable access to new antibiotics. So we appreciate your engagement and look forward to continue this important conversation in the future. So for the audience, just to mention that after closing the session, you will receive a survey. We invite you to complete to help us to improve for future webinars. And also you will find soon the record of this webinar on our websites from ICARS and GARDP. So thank you once again, and see you in the next webinar.
Thank you,
Bye.
everyone.
Thank you.
Thank
Bye.
you. Bye.
Bye.
Thank you. Bye.